Hello.
Here.
Mr. Stephen Schultz.
Here.
Ms. Miriam Sullivan.
Here.
Dr. Virginia Lemay.
Here.
Okay. Chair, that completes the roll.
Thank you, Bob. Thank you so much. Well, I want to begin by, first of all, thanking everyone for taking time out of your busy day once again, to review this commission report. I know that a lot of time has gone by since we last met, and it's easy to forget, but this is an important endeavor. We all understand how the cost of healthcare is rising, and if we can do something to curb that, I think we're doing a good thing. I want to begin by thanking the members that we've lost. We've lost a couple of members of this original commission to other career opportunities. I want to, on our behalf, congratulate Casey Stockman. Casey, I think the last time you joined us, you weren't officially a doctor, but now you're a doctor. So congratulations to you, Dr. Stockman. We're very glad that you stayed with us and you've had time to take time out of your day. So I'm asking all of the commission members, you've all received the report, and I hope you've had a chance to review it. And then I want to thank Mr. Millerick, Mr. Bob Millerick, the commission lawyer, for the excellent job I think that he did on this report. I know that Bob spent a lot of time crafting it. He went over the copious amounts of paperwork that we received. So, Bob, I want to thank you for what I think is a fair and comprehensive report, fair to both sides. So, that being said, you're very welcome. So, with that being said, before I weigh in with my opinion, I'd like to hear from the members of this commission your perceptions, your findings, and exactly what you think about the report. And I don't...
Madam Chairwoman, this is Ken. Thank you. If you don't mind, I'd like to just give a couple of thoughts.
Absolutely. Go right ahead.
Wonderful. Thank you. I also do want to thank you, Chairwoman, for leading this commission, and to Representative Edwards and Chippendale and the staff who worked on the commission and the report. I do have to respectfully disagree. I have considerable concerns about the report that I'd like to discuss. I think we all know that this bill has been introduced the past several years. The Senate has passed it unanimously, including in 2019. But in 2019, the legislation was in the kind of the waning hours of the session. And the opponents of the bill told House leaders that it would cost the state $3 million per year to implement step therapy. There was no claim. This claim was not substantiated. There was no evidence given. And the fact also, is that there's never been a fiscal note submitted with this bill. Advocates pushed back on this because there wasn't any evidence to this cost. Ultimately, it was decided that the study commission would be put together to review, and I'm quoting, review the cost impact for the utilization and prescription of augmented prescription drugs. In other words, let's find out if there would be a cost to the state, as the opponent said. And this commission, I believe, presented the perfect vehicle for the opponents to exactly tell us how much it was going to cost, where they're getting their information from. And unfortunately, we never ever saw that. The proponents, time and time again, showed study and analysis. We showed the 31 states who have passed step therapy and support it, and all without fiscal notes. And also, there are 5 states that currently have step therapy as law and are actually have legislation to strengthen it. So, if this was costing states money, I don't believe that 31 states would have passed it. I don't believe 5 states would seek to further strengthen the law. But despite the only recommendation that the report really comes out with is that it should be contingent on the further study of cost impacts. And the sole recommendation of the study commission is to determine exactly that. A study needs to be taken to determine the cost implications of step therapy. And that, in my opinion, was never done. If there is a cost to it, let's find out what it is. If there's not a cost to it, let's talk about what the other, problems with this legislation are. So, I'd also, the last thing I'll say on this right now is the report appears to be premised on that this step therapy will completely be abolished. That the insurers would no longer be able to use step therapy, and that is absolutely not true. If this legislation moves forward and it's passed, just like in 31 other states, step therapy protocols would still exist. There would be a generic carve out. So if there's a generic alternative, that generic would always be prescribed. It's all in the bill. And again, I don't understand if this commission was put together to find out what the costs would be related to passing step therapy. I still don't see it in here. And I've got some other, specific issues on some of the, pieces of the report, but I don't want to take up too much time. So in conclusion, though, I would respectfully ask that this report not be accepted as written, and that we come back together and really work through this and find out where we can get some common ground. So, thank you, Madam Chairwoman.
Thank you, Ken.
Sure.
Thank you. Anyone else?
Chairwoman, yes, thank you. So again, I wanted to join Ken in thanking you. Like you mentioned, this is a really important issue. So we really appreciate you pulling together this commission to discuss the issue. So we do share the concerns that Ken highlighted, but I also just wanted to point out that we're also concerned that the patient perspective isn't represented in the recommendations that are in the report. So through the process of these commission meetings, multiple stories were told about the impact that step therapy has on the patient community. And the recommendations that are focused solely on the further evaluation of costs don't really account for that impact. I actually coincidentally spoke with one of our volunteers yesterday who's recently diagnosed with stage 4 metastatic breast cancer. And she was actually sharing with me a story about the step therapy protocol that she's being put through right now. She didn't refer to it as such, but that's what it was. So her doctor actually prescribed her a medication to treat the cancer, the stage 4 metastatic breast cancer, at the beginning of April. And obviously, the purpose of this medication would be to prevent further metastases of the cancer. So she, like I mentioned, was...
We should put the TV on to see if we can get the step therapy commission, because this is blocking in and out.
So she, as I explained, was subjected to a typical step therapy protocol where her insurance company denied coverage of the medication that her doctor actually prescribed, and stated that she was required to try another medication first. So I will share that she explained to me that her doctor had prescribed the initial medication because it's more efficacious in improving prognosis for certain types of disease. Now, I certainly won't pretend to know all the details about the actual medication, but I do know it's related to specific hormone receptors and growth factors for her cancer. So her exact words to me were, was that she said, my doctor thought it was the best fit for my disease. And so, like I said, coverage for the initial medication was denied, and she was told she had to try another medication first. But the worst part of the story is that she was calling me because she was prescribed this medication in the first week of April, and she still has yet to receive any medication at all. So she was asking me, where do I go from here? What do I do? And I didn't really have an answer to share with her. I tried to help her the best I could. But my point here really is that this is time wasted that she truly doesn't have to lose. As a metastatic breast cancer patient, every day that she waits for these medications, her disease could be progressing. So really my point is this is just one story of how step therapy is impacting patients in Rhode Island. And while I think, it is important that we continue to discuss cost, I also think that we need to remember that we're talking about the lives and well-being of Rhode Islanders with chronic disease. And we really have the opportunity here to improve outcomes with the step therapy reform that's been proposed. Thank you.
I'm sorry that I'm joining late. I was having some technical difficulties. I don't know where we are right now, if the floor is open for other folks to speak.
Is that you, Dr. Ritzy, is that you?
It is. I'm sorry.
That's okay. I think I misspoke at the beginning of the meeting. I was congratulating Dr. Stockman for her having obtained the full MD, but I think it was you, Brittany, wasn't it?
What did I do?
Well, the last meeting we had, you were almost completed.
Yes,
okay.
I graduated early and everything, so I'm officially, yes.
Congratulations, Dr.
Yes, of course. Thank you.
Please proceed.
I just wanted to echo Ken and Corey. Frustrated when I read the report, to be frank. I thank you so much, Representative Serpa, for putting this all together. Your leadership has been really, really appreciated. I was told that this committee was to assess the potential cost of step therapy being implemented, and to see that after meeting several times, the big recommendation we have is to assess the cost of what step therapy the step therapy reforms might cost Rhode Islanders. I was a little bit surprised, because I thought that's kind of what we were trying to do this whole time. And I feel like we're kind of kicking the can down the road a little bit, if I'm being frank. It seems that we have multiple studies from 30 plus states who have enacted this similar policies already, and they have shown that there is no significant increase in cost to the state. So I just feel like we're kind of kicking the can down the road when we kind of already have data. And I think we have to not forget about the cost to the state to study this. So how are we going to get these numbers for the state of Rhode Island? Who's going to do that? How long is that going to take? And what is the cost of that? Because it's not free to put together a cost assessment. Other states have already done this, so I don't know if we really, it's going to be a big undertaking, I think, and we shouldn't just take it lightly. And so those are just and I agree with Corey that the humanity of this reform was just completely ignored, and the fact that this is something that affects patients day to day, it wasn't really emulated quite as well. And the big recommendation was solely focused on cost. I'll leave it there, but just my thoughts when reading the report.
Thank you, Dr. Ritchie. You always spoke very passionately, even during the months that we met. So I appreciate your input this time as well.
Sorry about the passion, but I can't help it.
No, absolutely. I'm glad you're a passionate MD. Otherwise, we'd all be in trouble if you didn't have some level of compassion in the work that you do, the hard work that you all do, especially in this entire past year. Is there anyone else who would like to speak?
Madam Chair, if I may.
Okay, go right ahead, my friend.
It's Rep. Chippendale, and
Yes,
without restating everything that has been stated, which I believe is 100% on the mark, I feel like we did sort of kick the can, and we missed an opportunity to nail down exactly what the issue was. We have lost the focus on the patients and their doctors and that sacred relationship that the insurance companies seem to have a much stronger ability to cause action on this particular initiative, because it's been before us for several years and it's just not getting anywhere. I'm not sure what it's going to take, but the evidence is clear from the other states, the majority of U.S. states that are doing this, that they believe patients and doctors know what's best for them, for the person being treated. And in fact, that is the case. And I think not only myself, but Dr. Ritchie and others gave personal stories during the hearings indicating exactly that. That the patients know their bodies and the doctors know their bodies best, not the insurance companies. So I was not entirely thrilled with the final findings in the report. Thank you.
Thank you, Whip. I appreciate your comments. And, you know, without revealing any information, I think if there's anyone on this committee who's had much experience with many doctors, it would be you. So I know that you too are speaking from the heart. And thank you for participating in this commission. I appreciate that. Anybody else who would like to speak today?
Yes, Madam Chair, I would like to speak. This is Yvonne Southwell. And, you know, what I have a question.
Please proceed.
Thank you. One thing that I would like to highlight, I appreciate all the comments that have been provided, but I do want to highlight and not lose sight that step therapies have been grounded in clinical evidence, evidence that has been demonstrated and supported by national guidelines, high levels of evidence specific to the reference to cancer and oncology, the NCCN, which clearly outlines the guidelines for treatment. And I think we shouldn't lose sight of that. It didn't necessarily come forward from the recommendation perspective, but it is important to recognize that step therapies do support and reinforce clinically appropriate treatments and guidelines that are supported by the broader consensus and experts in those fields. And so it's not so much not necessarily, you know, recognizing the prescriber and the relationship that they have with the patient. Certainly recognize that, and we treat patients individually. They're unique, and with step therapies in guidelines that are supported, along with the avenue to be able to support for that unique need for the patient, so that they can get the therapy that they want. That is the intent of step therapy at the end of the day. And organizations do have requirements to make sure that, you know, if a particular drug does not work for that individual, and they cannot use what's been defined in the step therapy, that there is an appropriate form to be able to support the use of that drug, supporting the patient as well as the prescriber. And I do think that that is an important. Cost is also equally important, and I do think that, you know, spending the time to really understand in a little bit more detail as it relates to Rhode Island the implications of cost for this particular reform would be time well spent, along with not losing sight of that patient relationship, as well as the evidence to be able to support the use of the step therapy guidelines and a form to be able to get the patients what they need when it's appropriate, and that the evidence and the documentation supports that.
Thank you for that. And anyone else would like to speak?
Hi, Chairwoman. This is Rich Pizzola with the New England Hemophilia Association. I'll be brief. I just want to echo what everything that has been said over the past 10 or 15 minutes. As those of us that are on the commission that represent patients come first. We are a patient advocacy group, and access and advocacy is at the forefront. And I just want to share that I too was deeply disturbed and a little bit disappointed that so much effort went into the patient advocacy to share real life situations, just like Corey did. And, you know, I know that we did on behalf of hemophilia patients, and there's not one mention of any real life examples in this report. I think that's really disappointing for patients who are going through these protocols like step therapy. So I would just ask, as a commission member, that the report goes back to reflect the copious amount of testimony and real life examples that were given on behalf of Rhode Islanders to make sure that the patient's story is being reflected in this report.
Thank you so much, Rich. And I agree that we did hear many, many stories, and I think I shared my son's own story, who suffers from a severe case of sleep apnea, and he had to be cardioverted in the hospital 2 or 3 times. And the cardiologist said that we just can't keep cardioverting a young man like this. So after some other tests, it was determined too that he had a severe case of sleep apnea. And we were rather concerned with the CPAP machines, plural, that he was given over the course of trying to determine which machine would be best for him. And the lower priced version didn't work for him. The second highest model didn't work for him until he finally got the model that worked for him. Naturally, it was the most expensive one, and he was a little annoyed at the facility that prescribed it. And he said, why didn't you give me this machine in the first place? And the response was, because your health insurance requires you to try the lower priced ones sooner. And when I think of the things that could have been, and Dr. Ritchie, you can speak to that better than I can, when I think of the things that could have been, because he would go into cardioversion again, I was pretty annoyed. But anybody else want to speak?
Madam Chair, Steve DeTroy.
Yes, Steve. Hi, welcome.
Thank you. I will echo all the gratitudes and platitudes to the staff and your colleagues for persevering through 7 or 8 meetings. Seems like so long ago. And I will echo all the comments of the previous speakers about the cost to patients. And but I also want to reiterate that the cost of treating patients that have to be put through step therapy goes up significantly in physician offices that have to deal with this. Now, we were on the phone with one of our health insurers the other day, and the medical director commented that the use of generic drugs by prescribers in Rhode Island is higher than other states that they're involved in. It's well into the 90%. So we're dealing with a few drugs. Many of them are brand names because they still have patents. The companies have done the work to do that. But at 95% of the drugs are still being generic alternatives, I think the cost of doing the medical practice is something else that we have not been able to quite figure into this report. So I am not prepared to accept the report either.
Thank you, Steve. Anyone else who'd like to speak?
Madam Chair, Sean Donahue.
Hi, Sean. Welcome. Please proceed.
Thank you. And I'd like to thank you for conducting this very important review. We at times got very passionate about this, and I commend the folks that are on the frontline heroes of not only this pandemic, but also of healthcare. But I do want to point out that this isn't only about the price of the drugs, but as Steve pointed out, 95% of the drugs are generic. The 5% that aren't cost over 50% of the total price of drugs. So 5% of the drugs account for more than 50% of the spending on drugs. But this shouldn't be only about the cost. This should be about the safety. And things get on step therapy protocol, as my colleague mentioned earlier, because a P&T committee had verified that there is an alternative medication that is equally effective to treat this condition. And why is it important to have this in place for safety? My colleagues from the North Carolina Blue Cross plan did a briefing on a very similar piece of legislation that pharma introduced in their state. And they found, after studying the extended release opioid prescriptions that would have been available to prescribers if there weren't for the step therapy protocol, that there was a 25% reduction in the amounts of long-acting opioid prescriptions that were administered or that were prescribed in North Carolina. So yes, they did find a savings of $225 million. North Carolina is a lot bigger state, but the more important finding was that there were 25% less long-acting opioid medications that were pumped into the system because of a step therapy protocol. So yes, the safety of the patient is the critical issue, and I'm happy to present this report supplemental. I just received it recently for the committee to look at, because there are safety issues for having step therapy, and just bring that to the table for consideration as well. It's not just the price.
Thank you for that. Would you please send that to Mr. Millerick, and he will disseminate it to the rest of the committee members, if you don't mind?
Yes, Madam Chair.
Anybody else?
Madam Chair, I'm sorry, I know I spoke already, but I just want to see if I kind of get the sense that this might be the only opportunity to not go through bullet by bullet, but just, I do have some questions on some of the bullets on the step therapy reform con side that I'd like clarification on. Is that okay to do?
Please proceed.
Oh, okay. So on page 5, it talks about that the opponents mentioned that this, reform would disrupt existing state or step therapy oversight framework, namely ACA and also OHIC. But again, we've got the law. I've got the law right here. As far as ACA is concerned, it says that states can adopt their own coverage appeal laws. So, I don't understand why that argument is put in there. Also, getting back to the OHIC regulations, we've got an email that I can forward from Amanda Clark from Department of Administration, and she says that the state self-insured plan is not governed by Title 27, so this would not impact the state as whatsoever. So I'm not sure where, there's a lack of, or just a misunderstanding, but I'll forward those to you and the rest of the committee. But there's other points in there about, for instance, the employers, based on a sample group of 90 employers, 80,000 employees, don't support step therapy reform. Maybe the employer, first of all, we never saw, the questions on how this poll was taken. I assume that this was taken by the Rhode Island Business Group on health. Primary sponsors of it are Blue Cross Blue Shield, Aetna, United Healthcare, Neighborhood Health, Tough Medical. Is this, I'd like more information, because if this is going to be used as proof that step therapy reform isn't supported, then I think we need to see that. And instead of maybe asking the employers, I'd ask the 80,000 employees who are patients and users and consumers of insurance, if they support reforms. And then lastly, again, it's noted that step therapy reform would cost millions of dollars because it's rapidly rising in large health care cost component. There's no evidence cited whatsoever, and I appreciate Dr. Christie shaking her head in agreement. And then finally, it says if it's weakened, it would be a cost increase. Again, zero evidence was submitted. In the meanwhile, we submitted lots of evidence to show that there isn't cost, that in a lot of fact, there's savings. And as far as the opponent's assertion about step therapy reform, I don't think there's one person on this commission, maybe I shouldn't speak for them, but that step therapy is not the problem. It's not the problem. The problem is when it takes days, weeks, and months to get a response back. And the opponents can say that they've turned these things around, but then during testimony, we heard nonstop from doctors and office managers and patients, the horror stories of it taking weeks and months to get a straight answer, or of being on a medication where they were perfectly fine and then being forced to go back to a medication that didn't work a year ago. So our problem is not with step therapy reform. It's about the doctor and patient having a say in the appeal process and getting these decisions quickly. There's no reason with modern technology that any doctor's office should have to fax an appeal request over to an insurance company. So I'm sorry, again, to be so passionate about this. I am, because, at Pfizer, listen, our scientists do not work so hard to make medicines. Only so the patients cannot access them. And anyway, I'll stop there, but I hope that we can get the evidence or the footnotes that, you know, on these assertions from the opponents of the step therapy reform.
You are muted, Chairman.
Anybody else that would like to speak? So what I did while all of you were speaking, I tried to take some notes. And what I consistently heard is that we don't have enough information from the opponents of the bill. And Ken, I think it was you who mentioned that, you know, your perspectives, well, not yours personally, but your side perspectives were very well represented. And we heard the stories of the impact that this has on patients. Dr. Ritchie, you were frustrated by the report, and you indicated that 30-plus states have enacted this policy. And again, we don't have the data from the other side. Rep. Chippendale, you indicated that evidence is clear from other states, and your priority is the sacred relationship. And step therapy has been grounded in clinical evidence, and we should not lose sight of it. We should consider the needs of the individual patients. Cost is time well spent. The Hemophilia Association, an advocacy group, disappointed that the patient advocacy was ignored. And I think that was the theme of the notes that I took. So is it fair to say that while we think that the people for step therapy did a fairly good job of representing the cost, we think that the cons were inadequate in their representation and that more information is needed from that side? And before we consider this commission folding, we should ask that side to present us with some fiscal impact information. Is that what I'm hearing? I'm looking for a nodding of heads at least, so that, yes.
Yeah.
Okay.
I would concur.
I'd agree with that.
You would agree with that? Okay. So, Mr. Millerick, can I put you back to work and get the information from the other side and see if the sample of the 90 employers and 8,000 employees were strictly from the Rhode Island Business Group on Health, or maybe you can get some numbers from another entity. So, Bob, would you be willing to do that? Mr. Millerick, are you there? Ooh, did we lose him?
He may be
Bob,
on
can you hear me?
See him talking.
Did we, yeah,
Yes,
are
I
you
can.
there, Bob? Okay. Did you hear me? Thank you. So, your assignment isn't complete. Did you hear me? Mr. Millerick, did you hear me? Oh, I think you need to unmute now. Okay.
Okay, yeah, Chair, I did hear the request, and I will go back to that employer group. The information came in through the Rhode Island Business Health Group, or I can't remember exactly the name of that
Okay.
group.
All right. And,
But, I'm familiar with the testimony that they presented, and
And I'm thinking that maybe we can get some more numbers from DBR regarding the costs of health insurance, because I think they are the entity that regulates it. Is that correct? Sean, you might know the answer to that. I
Right,
thought of,
you're exactly right. Within DBR, there's the Office of the Health.
audio
Insurance Commissioner.
difficulty.
okay.
Chair, I don't know if you can hear me, but you were exactly right. The Department of Business Regulation has within it an Office of the Health Insurance Commissioner, and that office regulates the marketing and pricing of insurance products for commercial products, Medicare products in Rhode Island.
Okay.
Madam Chair, may I make a suggestion that if any of the committee would like to put, in writing their concerns with the other side, both pro and con, that maybe they just take, whatever bullet point that was on there, and then maybe just put a rebuttal, or, what the nature of their concern is, and send it.
I think that's fair, Ken. And again, send it to Mr. Millerick.
Yeah, will do.
Okay.
Madam
Any
Chair,
other-
just thinking, to comment on Kenneth's point, Amanda Clark, on behalf of the Department of Administration, properly points out that a state statute can't impact an ERISA qualified plan, a plan that is under the ERISA statute. But that's 15,000 state employees. But we also insure almost 45,000 municipal employees, which would be subject to this statute. And the League of Cities and Towns has the authority to ask for a fiscal note. So that might be something to consider pursuing, is having the League of Cities and Towns take a look at the impact of their 45,000 employees and how it would impact their local taxpayers if a bill like this was to be enacted, or like the one that North Carolina decided not to enact.
Okay.
North Carolina passed that. They passed their bill. They have step therapy reform passed. They're one of the 31 states.
Yeah, but not in the form of House Bill 450. 31 states have 31 different approaches at this, Ken, and you have to put that on the table as fact.
Madam Chair, Steve Floyd.
Yeah.
For a little lightheartedness, because I don't know if I ever mentioned this to the commission members before, but Medical Society introduced the first step therapy bill in about 2011 or 12. It wasn't nearly as contentious because it was much simpler. It simply said that the insurance companies shall not practice step therapy. That was the extent of our bill. And now here we've come 10 years later to a commission to look at all of this. And I want to reiterate what Mr. Hisco said, that this is not an either or. Step therapy will still exist. We don't have a problem with step therapy. It's the execution and the over application of it that is of concern. It's not step therapy itself. And when business groups do their polling and whatnot, I'm very interested in their questions, because most of what I'm hearing from the insurance companies is dollar amounts if you do away with step therapy, and that's not the case here.
Okay, Steve.
Oh, and I also heard that they had to protect patients from doctors. That one I really enjoyed.
They had to protect patients from doctors. What was the last part, Steve?
That part I really enjoyed hearing about, that the insurance companies are using step therapy to insulate their patients from doctors.
Oh, Steve, that bill was introduced in, what did you say, 2011?
Oh, at least around there, and it was just very simple, but that there's been a step therapy bill in the legislature for almost every year in between. Sean might know because he tracks those better than I do, but for a while, after we had changed minds on it, gone different ways, the governor's office on disabilities had the bill for a while, and then it has evolved over the course of time to a much more comprehensive approach. So I'd say probably 2/3 of the year since 2011, there's been a step therapy.
Okay, and obviously it didn't go anywhere, not on either side, Steve?
Well, the early bills were a prohibition against step therapy. They weren't just step therapy reform as this bill is.
Okay. Okay, everyone. Does anyone else have any comments or input?
Madam Chair, if I may, I would just ask that we set a time for respondents to send their suggestions and or observations / comments to Mr. Millerick, so that poor Bob's not hanging out waiting for a million emails over the course of a month. Perhaps we take a date.
Sure. Okay, would 2 weeks be fair to everyone, do you think? Get your comments into Mr. Millerick within 2 weeks. And I suspect, Bob, that it's going to take you a while to collect all of this data from all of these entities. We are approaching May. I certainly don't want to ask anyone to come to a commission meeting over the summer. And then, Bob, this will give you time to collect your data. So maybe we could be in touch with all of you folks in the beginning of the fall season if you're willing. Is that fair? I don't think anybody wants to meet over the summer, or am I wrong?
So Madam Chair, that kind of, so we're under that scenario, then there really isn't a way for step therapy to be introduced this year for this session.
I'm sorry, Ken.
Yes, so under that timeline, then this would preclude step therapy legislation from being considered in the House and Senate.
Well, actually, I reintroduced the bill again this session. It was assigned to the Health Committee, and I went to the meeting. My testimony was very brief to indicate that the commission still hadn't finished its findings, so we didn't feel comfortable proceeding. So what I'm thinking, Ken, is that we're still uncomfortable with the findings, and we don't feel that anything is final. We don't think that it's concise enough to recommend passage. So, yeah, honestly, I'm thinking we couldn't pass that bill this session, unfortunately. Unless I'm thinking that Bob Millerick can get this information that quickly, but I'm just not sure. This is a lot of information for him to gather. I just don't think so. I'm trying to be realistic here, not contentious, but I just don't think so.
Going back to my previous comments, Madam Chair, Steve Detroit again.
Yes.
That's unfortunate, but I think in light of trying to get the best piece of legislation that balances the needs of all the parties, that may be inevitable.
Yeah. I think you're right, Steve. And I don't want to rush this and only to come back and amend it. So, I will certainly be here again in January at least, so that bill will be a priority in January if that's the end result of the findings. That will be a priority of mine in January, but I don't think, Ken, again, being realistic, I can't promise that we're going to have this information just yet.
Okay.
So, because actually, as we approach the warmer weather, the budget becomes the priority. So,
yeah. Well, listen, if there's a chance that you might be coming back in the fall, that hopefully that would be an option.
Not that I've heard of, Ken, not for any reason that I know of, but I suppose anything is possible, but I have heard no talk of that.
Okay.
So everyone's clear. We're going to get this additional information to Bob within a couple of weeks. Bob, you're going to proceed on with the Department of Business Regulation, with the business groups, and see what you can come up with that speaks more clearly to the costs. And again, you're right. We have to weigh the costs versus the well-being of the patients at the end of the day. So if nobody else has anything to add or to comment, I will be looking for a motion to adjourn.
So moved.
Seconded.
All in favor? Thank you. Thank you again, folks.